Hey everyone, welcome back to my channel. My name is Chasen. I'm an acute care nurse practitioner. I also happen to have over a decade of burn ICU experience and am board certified as a burn nurse. Burn nursing is a highly specialized and underappreciated specialty. To the best of my extrapolation abilities, I would guesstimate that burn nurses make up somewhere around 1% of all the nurses in the country. Today, I want to talk about burn resuscitation of critically burned patients. I know my burn nurses are well versed in this, so my target audiences for this presentation are the ED folks and pre-hospital providers who render initial care to burn patients. By the end of this video, you should be able to collect pertinent historical information, assess the different degrees of burn injuries, apply the rule of nines in estimating burn surface area, implement early burn care interventions, and recognize primary and secondary burn complications. The American Burn Association estimates about 450,000 people receive treatment for burns each year. An estimated 4,000 people die annually from burns. Burn injuries may be classified by their mechanism: flame, scald, electrical, chemical, contact, radiation, or other, such as cold injury. Burns greater than 20% total body surface area are generally considered major burns and require specialized care. A 47-year-old male escaped from an apartment fire. He woke up when he started coughing from smoke that was filling his room. He needed to pass through the fire in order to escape out the front door. He is being examined by paramedics on the scene. The patient is alert and oriented, breathing on his own, and covered in flame burns to the majority of his body. His blood pressure is 160/80, heart rate 120, respirations 26, and pulse ox is 95% on room air. EMS is preparing to transport him to the nearest burn center 15 minutes away. One useful pearl to remember is that burn patients are often not unstable in the first few hours. Many of them are still conscious on the scene and even in the emergency department. It is often possible to obtain a quick medical history directly from the patient. If there is early instability, consider other medical or surgical comorbidities. When receiving patients who have sustained burn injuries, there are some important components of the history and exam that will be asked by the burn center to help guide treatment decisions and predict complications. The first and most obvious question is the circumstance of the burn, i.e., what type of burn the patient sustained and how it happened. Another crucial piece of information is the time the burn injury occurred. This is used to calculate fluid resuscitation requirements. Next, it needs to be determined if there is concomitant trauma involved. Trauma stabilization must take precedence over the burns, and additionally, some burn centers are not even qualified to accept trauma cases. If the patient was involved in a fire, one of the predictors of complications is whether or not the patient was indoors or outdoors when they were burned. Upon initial assessment of the ABCs, note if there is any soot in their mouth, carbonaceous sputum, or singed facial or nasal hairs. These patients will often, but not always, require urgent endotracheal intubation. Although it can be challenging, the total body surface area that is burned should be estimated. I will later discuss how to do this using the rule of nines. The last important detail the burn center will want to know is if any burns are circumferential, meaning do the burns completely encircle any limbs or even the whole torso. Circumferential burns may go on to require an emergency surgical procedure called an escharotomy. Thermal burns are traditionally classified into three types: first, second, and third degree. Some references include a fourth degree, but this is not a very common occurrence. First degree burns, also called superficial burns, are red and painful but without blisters. A sunburn is a classic example of this. Second-degree burns, or partial thickness burns, are characterized by blistering. They are pink or red, wet, and hypersensitive to touch. Third-degree, or full-thickness burns are charred or white, leathery, firm, dry, non-blanchable, and insensible to light touch. A fourth-degree burn is one that penetrates deeper than the skin where muscle, tendon, or bone is involved. Now that you understand the different degrees, you must be able to approximate the total body surface area burned. In the burn center, they utilize the Lund-Browder diagram to make a more detailed estimation of the TBSA. But everyone else can use the rule of nines for a more rapid assessment. Bear in mind that the rule of nines only applies to adults and not children or infants. The main sections of the body each represent a factor or multiple of 9% of the total surface area. On just the anterior side, the head and each arm represent 4.5%. Each leg is 9%, and the torso is 18%. If you repeat that on the posterior side, you get 99%. The last 1% is given to the PP area. When estimating TBSA, you only include second and third degree burns. First degree burns are considered trivial and not included in the estimation. For small or scattered burns, the burned area can be estimated by using the patient's own hand, which represents approximately 1% of the TBSA. This is known as the Palmer method, but remember it includes the patient's palm and fingers as well. When caring for critical burn patients, do not get distracted by the appearance of the burns. Wound care is one of the lowest priorities and happens only after the patient has been stabilized. Just cover the burns with a clean, dry sheet and leave it for the burn center to manage. This allows them to easily assess the burns without having to remove any gauze or ointments. For those providing the initial resuscitation, I have created a mnemonic to help you remember the most important early interventions. When you receive a major burn greater than 20%, just remember, I owe you water. I is for IV fluids. Stick in a couple of large bore IVs or a lovely central line and start lactated ringers. Calculate the patient's fluid requirement using the Parkland formula, which is 4 mLs per kilogram per TBSA divided by 16. This is your initial hourly fluid rate. If calculating the Parkland formula is not feasible, just run the LR at 500 mLs per hour. Fluid resuscitation is one of the highest priorities to prevent burn shock and subsequent organ failure. O is for oxygen. If there is any concern for inhalation injury or carbon monoxide poisoning, place the patient on 100% oxygen by non-rebreather mask. Carbon monoxide has a half-life of 4 hours on room air. This decreases to 1 hour on 100% oxygen. Do not hesitate to intubate the patient early if there are clinical indicators of airway compromise. The airway can swell shut rather quickly. U is for urinary catheter. Insert a Foley catheter and discard the initial urine. Hourly urine output measurements are used to gauge the adequacy of fluid resuscitation. A Foley catheter should also be inserted in the presence of severe genital burns to maintain urethral patency. Never administer diuretics in burn patients. It will negate monitoring efforts and potentially lead to worsening hypovolemia. Low urine output is almost always from a fluid deficit. W is for weight. An accurate dry weight is necessary to calculate medication and fluid requirements. This should be obtained as early as possible for accuracy and to guide clinical decision-making. A is for analgesics and anxiolytics. Burns are a very traumatic experience, and pain control is a high priority. Morphine and Versed were the preferred drips at my center, but use whatever you have available or are most comfortable with. The goal is to keep the patient comfortable and calm. T is for tetanus prophylaxis. Administer a tetanus vaccine if the patient has not received one in the past 5 years. This can be delayed up to 72 hours to ascertain immunization status. E is for enteral tube. Insert a nasogastric or orogastric tube to initially decompress the stomach. Anxious patients can swallow considerable amounts of air and distend the stomach, increasing their aspiration risk. Enteral feedings will be initiated at the burn center to meet the patient's hypermetabolic demands. R is for rewarming. Body heat is rapidly lost through damaged skin, which places the patient at risk for hypothermia and its associated complications. Try to keep the room as warm as possible. Apply warm blankets, use a bear hugger, and infuse fluids through an IV fluid warmer if available. The final topic I want to discuss is about complications. Burn pathophysiology is complex and can result in numerous complications. Primary complications are a direct result of the burn injury, whereas secondary complications arise from our treatment of the patient. Burn shock is one of the main primary complications we try to prevent. Burn shock is worse than your average shock state because it's a combination of hypovolemic, distributive, and cardiogenic shock. As mentioned earlier, carbon monoxide as well as cyanide poisoning are dangerous complications from smoke inhalation. A patient who was indoors or in an enclosed space is at much higher risk for these complications. These are highly fatal complications if not identified and treated promptly. Hypothermia can happen quite rapidly as the body can no longer retain heat. Cold environments and room temperature IVs can exacerbate this further. Acute renal failure is unfortunately a common complication of extensive burns. It is not uncommon for patients to require renal replacement therapy. Venous thromboembolism is a concern for many patient populations, including those with major burns. Burn pathophysiology yields a hypercoagulable state, and VTE prophylaxis is paramount. Curling ulcers or stress ulcers, while a known complication, are not that common as long as enteral feeding is initiated. If tube feedings are on hold for a prolonged period of time, stress ulcer prophylaxis should be added. Infection is probably one of the most obvious complications, but is not an immediate concern. We generally do not worry about infection until several days after the initial burn injury. As such, patients do not require prophylactic antibiotics, and physicians should refrain from ordering them unless there is a high suspicion for an active infection. Compartment syndromes are secondary complications that can occur with overresuscitation. Excessive amounts of fluid will third space everywhere and can increase pressure in the limbs, abdomen, and thorax, necessitating surgical decompression. When excessive fluid extravasates into the lungs, it can cause acute respiratory distress syndrome or ARDS. Nearly all critical burn patients end up on mechanical ventilation. Sometimes, higher pressures are needed to maintain oxygenation, and development of a pneumothorax is also a potential complication. For those of you who do not encounter burns on a daily basis, I hope I was able to better equip you for the initial management of critical burns. If you found this video useful, please consider liking and subscribing. Thanks for watching, and I hope you will join me in my next video.